I have no disclosures. Most of you know this, but some of you may be interested in the etymology of this word, leukodystrophy, and obviously it has to do with the white matter. It has to do with the growth or the nurturing of the white matter, and obviously there is a problem with that. Sure enough, the most robust manifestations from the imaging point of view, histopathological point of view in these conditions may affect the myelin itself, and those changes may include quantitative changes and qualitative changes, but it would be a mistake to limit the concept of leukodystrophies or leukoencephalopathies to abnormalities of the myelin itself. Indeed, it has to do quite understandably, some conditions have to do with the health of the myelin-producing cells, the oligodendrocytes. The integrity of key support systems, such as the astrocytes, the vessels, can be very important in understanding the mechanisms leading to apparent myelin abnormalities, white matter conditions, abnormalities. When we discuss this from the imaging point of view, we have to consider reactive changes which may intermingle with the primary abnormalities such as inflammation, edema, and ultimately many of these conditions lead to very profound tissue matrix changes which may again dominate the imaging phenotype towards the end of the disease process and when the actual primary changes are not discernible anymore. From the imaging point of view, the definition of a leukodystrophy seems to be easy, although I could go in great length and show those mimics, following Thierry's previous talk. But yes, again, a leukodystrophy may be defined in a very crude fashion by CT hypodensity and T2 hyperintensity, involving significant portions of the white matter. And that would be easy, but in real life what you see is more like this. So yes, indeed, there are conditions which are characterized by almost exclusive gray matter abnormalities, and those we may call polyodystrophies. And then there are a few conditions which are characterized by almost exclusive white matter changes, more or less uniformly involving the brain, and those are the two extremes. But unfortunately, most of the bulk of the other conditions fall between the two, and so we may call the case here here as a leukodystrophy quite rightly, because that's what it looks like. But indeed, please note that some gray matter structures are involved as well, and this case, for example, here has, at least on this image, gray and white matter involvement in more or less equal proportions. So those are the pan-dystrophies, but still, for example, in this case, the dominant substance involvement is that of the white matter. However, it's very generic when we say T2 hypersignal, right? So this is T2 hypersignal, so you may want to call it leukodystrophy, but this is T2 hypersignal, and you can quite legitimately call it leukodystrophy, but it's a totally different condition. This was metachromatic leukodystrophy. This is now a megalencephalic leukodystrophy with subcortical cyst. This is a leukodystrophy, but it's homocystinuria, and this is again a leukodystrophy-like appearance, extensive white matter changes in a 13-month-old child. But this is yet another condition, which is non-ketotic hyperglycemia, and this is a therapy-induced white matter disease, and I think this is what we should call, leukoencephalopathy. However, these all look like, extensive T2 hyperintensities involving dominantly the white matter of the brain, supratentorial brain. But it's important to recognize that, this is just the imaging phenotype, right? So just looking at the T2-weighted images, you don't get much information about the underlying mechanistic features of those conditions. This one is indeed related to a desmyelinating process. This histopathologically is vacuolating myelopathy, and actually mechanistically it's a water homeostasis problem in the white matter. This is a demyelinating process, which happens to be reversible, by the way, because it has to do with a myelin maintenance problem. This is actually just delayed myelination. And again, as I said, this is an exotoxic leukoencephalopathy. The underlying mechanism we may not fully understand, but it's important to recognize that the imaging phenotype may cover a lot of different mechanistic reasons. I think it's important, as with everything, to have a few good, robust definitions and have a good understanding of what those mean. Delayed myelination is probably the easiest to understand. We all know that there is a predefined timetable for myelination, and we know what the brain should look like at birth, and then 3 months and 6 months and 12 months on T1 and T2. This can be found in every textbook, and you as pediatric radiologist, I guess most of you may be pediatric radiologists here, you know how to determine bone age, so it's not much different from that concept. It's important to recognize, however, that this is not necessarily a permanent problem. So sometimes you may see progress. It may be delayed, the myelination, but it may still progress. So it's not a definite state. Here is, a case, a 13-month-old kid with non-ketotic hyperglycemia. You see definitely the myelination pattern is not appropriate for the age of this patient. Just to make sure at this age on T1 weighted images, the brain should look like more or less fully myelinated, and clearly there is not much myelin within the peripheral areas of the cerebral hemisphere, so this is not a difficult thing to determine that this case is a delayed myelination. Now, is it permanent? Of course not. This kid, you do a follow-up study later at 3 years, it's still not normal, right? The image on the right side, it's still not normal. But there's a clear progression of the myelination process in between the two studies. So this is delayed myelination with interval progression of the myelination process. Now, there is another condition which has become very popular, and a lot of entities have been described in recent years, labeled as hypomyelinating conditions. I believe that this may be a little bit abused, because I'm not sure if we always have a good understanding of what we mean by hypomyelination in these conditions. Normally, at least the best definition as of today is that this would be a permanent failure of the myelination process, and actually to confirm the diagnosis of hypomyelination, you need 2 MR studies. I believe it's like 6 or 9 months apart, and should not any change. So it should be basically an arrested myelination, a permanently arrested myelination with insufficient myelin within the white matter. Now again, if you have only one study, it may be very difficult to confirm the conditions unless it's a syndrome with other features which make the diagnosis more obvious. Now, one of the best known of these conditions is Pelizaeus-Merzbacher's disease that you see on the left side. But for example, this one, the 4H syndrome, the hypomyelination, hypogonadotropic hypogonadism, and hypodontia, is another condition which is called hypomyelination, but I'm not sure if it's really true. And but that's the way it's called. So there is a bunch of conditions, entities which are labeled as of today as hypomyelinating, but I'm not sure if it's always true. Dysmyelination is another important term. It has to do with the composition of the myelin. The myelin has a very well-balanced composition of key constituents, and if this balance is somehow disturbed, that may impact the integrity, the structural integrity of the myelin, and what happens is that this myelin may become prone to breakdown. It becomes fragile and prone to breakdown. And we have several examples for that. We know that, for example, in metachromatic leukodystrophy, cerebroside 3 sulfate content will increase from the normal 3% to, for example, 30%, and this will fragilize the myelin. In XALD, we all know that there is an incorporation of abnormal quantities of very long-chain fatty acids. In a condition which is also labeled as hypomyelination with congenital cataracts, we know that there is a deficiency of a protein which we don't quite understand what it does, but it's called hixin. And then, as we have seen in Pelizaeus-Merzbacher disease, we know that there is a defect of the proteolipid protein. And again, the end of all this, either of these conditions, is that the myelin may become fragile, unstable, and therefore prone to breakdown, which will manifest occasionally with demyelination. The problem with demyelination that there may not be any obvious imaging feature or abnormality until the process leads to actual demyelination. So before that, you may not see much on the images, maybe a little bit of delayed myelination or hypomyelination, but you don't know. One topic that has again become very popular and hot recently is the impaired myelin water homeostasis, which may be primary and secondary. And what is characteristic in these conditions is that the premorbid myelin is actually normal. So there is nothing wrong with the myelin at the beginning, but there is a problem with the maintenance of the myelin or the homeostasis, the water homeostasis of the myelin. And examples of that could be the subacute combined degeneration in cobalamin and folate deficiency and inborn errors of the methyl transfer pathway. Here is one case, homocystinuria case. You see that there is extensive white matter disease with the restricted diffusion consistent with an acute ongoing myelin breakdown process, intramyelinic edema probably. There is the other component in this group, the impaired water homeostasis. And we have known that for a long time that in Canavan's disease, probably there is some sort of impaired osmoregulation, and that may manifest with leukodystrophy-like appearance. But more recently, in megalencephalic leukodystrophy with subcortical cyst, investigators from Amsterdam found that this was actually basic. So the myelin has no problem. The problem is actually a potassium siphoning process, which is impaired, and that will impact the cell volume regulation in astrocytes, and this will create an imbalance a problem in the myelin maintenance, and that will lead to the demyelinating process. And more recently, another mechanism has been described, which has to do with the CIC2 chloride channel integrity. And the mutation has been identified. So I think we are going to hear a lot about this. Again, it's important because, again, this is not a primary myelin problem. It's a myelin maintenance, or more specifically, a myelin or it's a water homeostasis problem, which will adversely affect the structural and ultimately the functional integrity of the myelin as well. Now, this is a case of Canavan's disease and the corresponding diffusion weighted images showing the restricted diffusivity. But this case looks on the T2 weighted images quite similar, just a diffuse leukodystrophy all over the place. Yet, if you look at the diffusion weighted images, this is characterized by increased diffusivity, and this is actually a chronic brain edema because of the water homeostasis problem that I've just described to you. And that's why it's megalencephalic, by the way. And finally, demyelination. Again, the definition is loss of the normal or abnormal myelin, whichever condition applies. Now, the time scale of the process of the demyelinating process may be different in the different conditions depending on the underlying mechanisms. It can be acute, subacute, chronic. Some of those I have shown you may be reversible, others may be irreversible. But ultimately, this is oftentimes the end phase of many different pathways adversely impacting on the functional or structural integrity of the white matter. Now, common causes of demyelination that's a long laundry list, right? So it can be ischemia, it can be trauma, infection, inflammation, osmolar stress, myelotoxicity that we do during treatment of conditions, but some of those are endogenous myelotoxicities in some of the inborn errors of metabolism, and we have seen that demyelination, probably other processes that we don't quite understand yet. Now, how do we evaluate demyelination? It's easy if you have more than one study available, and you know that, for example, in this kid, at the age of 8 years, the brain was perfectly normal, and then the patient comes at the age of 12 years for whatever clinical reasons prompting a new workup, and this is what you see. So clearly, this cannot be anything else but demyelination or demyelinating type of process, because you know at 4 years earlier it was more or less normal. It's a little bit more challenging if you have only one snapshot But you can probably still get some clues about it. For example, since we know the progression pattern of the myelination process, and we know that, for example, splenium should myelinate before more anterior portions of the corpus callosum. So if you see abnormal signal in the splenium, there is a chance that it has to do with the demyelinating process, because more anteriorly you see a more or less normal looking corpus callosum. So this is possibly a demyelinating, or likely a demyelinating process. This is more subtle on the right side, because we also know that the immediate subcortical white matter structures are among the last to myelinate. So if you, on this image, if you see that those structures are relatively preserved, but deeper in the hemispheres you have a paucity of myelin, that this may be also a demyelinating process. I think the fundamental concepts that we need to remember when dealing with these conditions, and with many others, by the way, but now we are talking about leukodystrophies, is the concepts which were laid out some 20 years ago by investigators from the Netherlands, Professor Walk and Mario van der Knap, and these are the concepts of pattern recognition and selective vulnerability. And these concepts by no means are exclusive to metabolic disorders or white matter diseases, but we use those every day in other conditions as well, but they are particularly applicable to this. So what is a pattern, actually? Well, the lesion pattern is, at least for us, that's the, in a sense, the imaging phenotype, which is the constellation of lesions and non-lesions. One of the most striking features of some of these conditions is that some structures may be heavily affected, and a few millimeters aside, it's perfectly normal. So there is, some structures are vulnerable, others may not be, and this creates some sort of a gestalt, and a constellation, which may be helpful for imaging diagnostic purposes. And these differences reflect selective vulnerability between different structures, versus selective resistance of some others to the same noxious effect, for example. What should we do? I think one of the most difficult things, at least when I started dealing with these conditions more intensely, was to be organized, right? Because sometimes these conditions can be so overwhelming when you just look at the images, and so you have to get organized, and you have to get calm and organized. So you have to go systematically evaluate each and every structure and try to identify what is normal and what is not normal. And so, you have to scrutinize all white matter structures in the cerebellum, brainstem, spinal cord, supratentorial, different structures, internal capsule, external capsule, subcortical U fibers, and so forth. However, there are some other features, more global features that should be evaluated. For example, uniformity or non-uniformity of the white matter involvement, and here you see three examples in which it's almost uniform. I mean, there may be some myelin left in the corpus callosum in some of the areas in the deeper structures, but it's a very uniform involvement of the cerebral hemispheres. But look at this one, for example, here, these cases, the involvement is non-uniform. Here on the left side, you see that the subcortical U fibers are involved, but the deep white matter structures are not. They appear to be normal, so there is some sort of a gradient in the abnormalities, the most superficial structures being more heavily involved, and the deeper ones are virtually spared. Here you see just the opposite. The deepest structures are affected, and the most superficial structures are not. So it's the opposite gradient. Here you see that anterior frontal lobe structures, white matter, is much more severely affected than the posterior ones. And here you see again the opposite, in which posterior white matter is more affected than more anterior ones. Now, this is one snapshot in time, so this may change in time, but sometimes, if you are lucky, you can still see this. Now, these processes are dynamic, they progress, so ultimately everything may be involved, and then it's going to be difficult, but sometimes these kind of progression gradients may be helpful. Again, here you see the centrifugal progression pattern. This happens to be a complex 1 deficiency. This is the opposite, the centripetal progression pattern, which In this particular case, this is L2-hydroxyglutaric aciduria. Now you can quantify that if this is the same patient, now with ADC map and FA map, and you see how the ADC increases towards the periphery and the FA increases towards the deep structures. So now we can measure it and even monitor the evolution of the process. Here you have the anteroposterior progression pattern in megalencephalic leukodystrophy with subclavicular cyst, and I don't know what this one is, but it's just the opposite. And you can have a combination of those, for example, in XALD, at the same time posterior-anterior and centrifugal, right? If you think about it. And remember that the corpus callosum is sometimes the mirror of the cerebral hemispheres, what's going on in the hemispheres, and you can beautifully see in this particular case that kind of gradient of lesion involvement from posterior to anterior. There are some special patterns which may be helpful. One of them is the so-called tigroid pattern. Most of you may know this. This is quite characteristic to juvenile form of metachromatic leukodystrophy. So if you see this, it's a very strong diagnostic clue. And there is another one which may be called retrograde demyelination. This is classic. One of the classic examples is L2-hydroxyglutaric aciduria again. It's the oldest myelin somehow that appears to be normal. I mean, if you look at these images with a little bit of extrapolation, you could argue that this is the at least what is myelinated, where the myelin is normal. This could be more of this kind of pattern could be normal for a child of I don't know 6-7 months of age. Whereas the myelin that should develop later is abnormal. And here you see another, it's not limited to that one. This is, again, homocystinuria with cystathionine beta synthetase deficiency. And you see the same thing, that the oldest myelin that should be present at birth and during the first few months of life, that is relatively spared at least this stage of the disease. And the newer myelin is involved. And just look at here, even here in the central structures, the myelin is relatively spared compared to some others. And if you look at in the coronal images, you can appreciate the same. And if you compare those with the original images from the Flechsig book from the early 20th century, then you really see the same thing. Head circumference is also a feature that is not strictly imaging feature. We don't always know what is the head circumference of our patients, but sometimes we can get a clue just looking at the images. Some heads are bigger than they should be and others are smaller. And this is also a helpful classification scheme or a helpful tool to argue on the potential differential diagnostic options. And please note that this is an edema that if the edema develops in the young child before the sutures close, then you will have a megalencephalic leukodystrophy, like in Canavan, like in MLC. But please note that, for example, in this case, the cerebellum is not that much involved and it's not enlarged. So it's really the supratentorial compartment of the skull that accounts for the megalencephalic appearance. The posterior fossa remains relatively small because there is no edema in those structures. So what is the optimal MR imaging technique or strategy? Well, because you are dealing with white matter abnormalities, it's in your best interest to use myelin-sensitive sequences. Should we inject these patients? I don't think so. It may appear useful in some conditions, but I think the yield of contrast injection is not that high. Diffusion-weighted imaging is more helpful because what may look quite similar on T2-weighted images can look very different on diffusion-weighted images, and this may give you some clue about the underlying mechanisms. Spectroscopy, well, oftentimes you get a totally non-specific spectrum in these cases which will not help you at all. You will have a little bit of increased choline, you will have some lactate, a decrease of NAA, but do you know what it is? Of course not. Sometimes you may be a little bit more lucky, like in Canavan's disease, you get this huge peak and it makes it very obvious what it is, but do you really need it? Actually, I believe that you probably could come to this conclusion just based on the conventional imaging. You may not really need it. But sometimes it's still helpful because when the imaging findings are not diagnostic conventional imaging findings, like in this case, you have a clue already what this could be, but you don't know. And in that case, especially if you are using the right MR spectroscopic technique, which in this particular case is not the short echo time, but more the long echo time, then you may actually upgrade your initial diagnostic hypothesis, which may have been suggestive, to a definite diagnosis using spectroscopy. So, and sometimes spectroscopy is the answer now. This is quite rare, I understand that, but you may not be able to make the diagnosis, at least from in the MR suite, if you are not using spectroscopy like you see in these two cases. The NAA peak is missing on the left side and the creatine peak is missing on the right side. Leukodystrophies, I think it's a little bit provocative, I understand, but could be characterized as true leukodystrophies or apparent leukodystrophies, which look like that, but they are not primary problems. And the true leukodystrophies are typically genetically determined. They are caused by dysmyelination or impaired myelin maintenance or homeostasis, whereas the apparent leukodystrophies or leukoencephalopathies may be inherited, but typically oftentimes acquired and caused by something else. I know it's not very scientific, but it can be caused by a lot of other things. And these are probably the conditions that are rightly called leukoencephalopathies. In neonates, infants, and children, leukodystrophies and endotoxic leukoencephalopathies are common. In adults, the other conditions, acquired toxic leukoencephalopathies, inflammatory white matter disease, ischemic infection, and so forth. So one classification which will be discussed later, I think, by other speakers, which was developed for neonates, but is still helpful for white matter diseases, is this one, that inborn errors of metabolism can be classified in any of these four conditions. And the major groups in each of those, like in the intoxication group, is aminoacidopathies, and you have seen already this one, when in the newborn structures which are already myelinated will be affected, and you see it here on these images that only the myelinated structures are affected, and diffusion-weighted imaging is I don't want to spend too much time on this. Organic acidemias are typically associated with gray matter involvement, but please be prepared that in some conditions, white matter changes may dominate in organic acidurias, such as this one again, which you have seen, glutaric acid type 1, same thing. You can have gray matter involvement, but a lot of white matter involvement. And here you see one case where you have minimal gray matter involvement and a lot of white matter involvement. Again, this is organic aciduria, so it's a little bit unusual. In congenital urea cycle defects, it's a huge edema that oftentimes dominates the imaging pictures, and that's why these images are so bright, for example. So it's just an apparent leukodystrophy, it's not a leukodystrophy. And then sugar intolerances, such as galactosemia. Look at this. If you scrutinize these images, they really look like megalencephalic leukodystrophy with subcuticus cyst, yet it's not. You do spectroscopy, and you will see the galactitol peak here at this location, and you get the diagnosis. Congenital lactic acidemias, this is very interesting because you can have, we always associate mitochondrial disorders, whatever those mean, with gray matter abnormalities. But look at this one. This is a big time white matter abnormality without any involvement of gray matter structures. Very rapidly necrotizing conditions which are characterized by restricted diffusivity at the beginning of the disease before it goes the brain gets to a complete meltdown and the burned out stage. And this is very characteristic appearance, and we start seeing more and more of these. And these are, really hyperacute supratentorial myelin breakdown, characterized by restricted diffusion, rapidly burning out, and a lot of mutations can present, different mutations can present with the same imaging phenotype. So let me give you a few clues to the SAM questions. In mitochondrial cytopathies, the brain involvement is not exclusive to the gray matter, in particular to basal ganglia. Brain involvement often presents with a leukodystrophy-like appearance in these conditions. Brain involvement is actually very common. Different mutations may present with similar MR imaging phenotypes and vice versa. That's a very important concept about these conditions. And initially, brain lesions are often characterized by restricted diffusivity. In disorders involving complex molecules, and I'm just using these two groups, the peroxisomal disorders and the lysosomal disorders, to illustrate two important concepts. In particular, factors which may influence the imaging phenotype in these conditions. This is actually the genotype, the mutation itself, the stage of the disease, and therapy. The biochemical phenotype, actually, which is defined by the genotype, will define the magnitude or scale of the metabolic derangement, and peroxisomal disorder is a good example of that. If you have abnormalities related to the disorders of the biogenesis of the peroxisomes, you get very severe diseases with very early onset in life, whereas if it's a single enzyme disorder, it may have a later onset and the outcome may be much more benign, and then you have conditions in between. So that's, I think, a very important concept, the age of onset, severity, earlier age of onset, more severe disease, later onset, less severe disease. And look at these three cases, peroxisomal disorders, all three of them. One of them is a biogenesis disorder here on the left side. It presents with polymicrogyria, very severe delayed arrested myelination, and it's a very severe condition, very commonly leading to death. Then you have a different condition, which is a single enzyme, which will have a later onset, XALD, and the prognosis is again poor, but then you have another single enzyme condition, adrenomyeloneuropathy, and it will have an even later onset and a really, compared to XALD, a mild clinical course. Yet, these are all peroxisomal disorders, but the magnitude of the metabolic disorder is very different. So these are some clues again to your SAM questions. We are going to go through that after this session. And again, let's see the residual enzyme activity. How does that influence the imaging phenotype? And metachromatic leukodystrophy is a good example for that. We know if the residual enzyme activity is less than 2%, you will have an infantile onset. If it's between 2 and 5%, you will have a juvenile onset. And you have more than 10% of your normal enzyme activity, you may be asymptomatic. So that's very important again. Stage of the disease. Remember I told you these are dynamic conditions. So it may be totally normal at the beginning, the imaging study. Then you may get the full-blown imaging phenotypes, which you would want to put in a textbook. But in the burned-out phase, it may be, again, totally non-specific because everything is gone. So you have no diagnostic clue anymore. So that's, again, important, the concept of dynamic imaging patterns. And luckily, more and more therapy can influence the imaging phenotype. Here I'm showing you a case of XALD pre and post BMT, and you see that these changes, which were not very prominent at the beginning, indeed improved on treatment, and you can see the same on the sagittal images, and even in the brainstem along the pyramidal tracts, that there is indeed improvement. And this is the last set of clues, regarding head circumference. Changes are common in leukodystrophy, so that's important. Unlike in acquired leukoencephalopathies, increased head circumference is a characteristic feature of patients with Canavan's disease. Please remember that. Macrocephalic leukodystrophies also include L2-hydroxyglutaricaciduroid, Alexander disease, and the vanishing white matter. In true leukodystrophies, lesion involvement of the cerebral white matter may or may not be uniform and complete initially, and in leukodystrophies, lesion patterns including lesion gradients change over time. Take-home messages are these. I think definitions are important. We can use whatever definitions we want, but we need to make sure that we understand the same thing when we say that. And I think, as with a lot of other things in life, meticulous image analysis and pattern recognition are really key. Now, this will happen every now and then. You don't know what it is. What do? Keep calm and carry on, right? Or alternatively, cheer up. Maybe you are just being lucky and you are about to discover a new entity.